Okay, it's
Yeah,
okay.
yeah. Thank you.
Okay, Dr. Liang. Now I leave
Yes.
this for you, and please start this webinar.
Okay. Well, good morning, good afternoon to everyone, and welcome to this APSC Club for a Forum of Cardiovascular Disease Series, Implementation of the Artificial Intelligence in Prevention and Precision Therapy for Cardiovascular Disease, Now and the Future. Together with me is Professor Lin from National Defense Medical University and the Church Service General Hospital, Taipei, Taiwan. And program chair is Professor Julie Lin, National Taiwan University Hospital, APSC Cloud. Today we have an honor. My name is Zhong Liang, and I'm from Duke NUS Medical School, National University of Singapore, and also National Heart Center in Singapore. So today we have honor have a few speakers coming from the Philippines, Taiwan, Thailand, Korea, Singapore. So first speaker is Joy Donato, and from the Philippines. He's a clinical social professor at the University of Philippine College of Medicine. He's also chairman, Asian Society of Echocardiography, Manila, Philippines. Followed by the Dr. George is Dr. Wei Tin Liu from Taiwan, and he is an attending physician and from Division of Cardiology, Department of Internal Medicine, Church Service General Hospital, Taipei, Taiwan. So he will talk about the prediction of the sudden cardiac death by AI and ECG. Following by is Dr. Rompichev from Thailand, and he is associate professor of medicine, co-chair at the Center of Excellence in Arrhythmia and Sudden Death, and from Chulalongkorn University, Bangkok, Thailand. And then the next speaker is Dr. Sho Hun Yong from Korea, and he is a clinical assistant professor from Division of Cardiology at the Department of Internal Medicine, Seoul National University Hospital, Seoul, Korea. So last speaker is myself. Yeah, again, so I'm from the Duke NUS Medical School, National University of Singapore, and also the clinician innovator at the National Heart Center, Singapore. So welcome all speakers. So let's start the first speaker. So welcome Dr. Yos Donato Magono from the Philippines. And again, Dr. Yos. Okay, so your slides, please, your time.
Hello, warm greetings to everyone, my dearest colleagues and guests from the Asia Pacific region. Welcome to this Asia Pacific Society of Cardiology webinar, and I'm pleased to represent the Philippine Heart Association. These are my disclosures. I'd like to focus our attention at the get-go on something that's very vital to our understanding of heart disease. That is Brugada syndrome. And I will try to do this in a brief period of time by focusing on three things. First one is the burden. How prevalent is Brugada syndrome in the Asia Pacific region, and what is its clinical presentation? Second is recognition. How do we pick up subtle signs of Brugada on your standard electrocardiogram? And finally, of course, your solution to the problem. What are the possible strategies to blend or incorporate artificial with genuine intelligence, or AI and GI? Let's start with a clinical scenario here. Let's say you are at the clinic and you're faced with a young male who's fairly asymptomatic, but has a history of sudden cardiac death in the family, unexplained. And this patient wants to join a triathlon, very rigorous activity. Maybe one of the first questions we need to answer is, can we truly pick up disease early on and predict certain events? So we do a 12-lead electrocardiogram, arguably one of the, if not the most accessible and vital tools of trade for the cardiologist and the internist And the next question in the mind of the patient and the physician probably is, are there any subtle clues that we can pick up on your 12-lead ECG to maybe suggest certain important cardiac conditions? And we focus on Brugada syndrome. So what basically is Brugada syndrome? We know for a fact that it is actually genetically linked to the sodium channel, and the presence of this mutation increases one's likelihood of developing arrhythmias and even sudden death. But ultimately, to diagnose Brugada, you need a combination of clinical, historical data, as well as ECG data. How prevalent is it? Worldwide, the number is 1 out of 2,000, but in certain regions in the world, especially Asia and even in the Philippines, it is probably much higher, as you will see here in this particular graphic, 1 out of 500 individuals. To help you get a very quick glance of what Brugada is, I've summarized for you the things to remember. Take time to detect the vital and fine signs of Brugada syndrome. The first requisite is an electrocardiogram, which demonstrates a type 1 Brugada pattern. And what are the classic findings here? Your J point elevation, which is at least 2 millimeters, coupled with a cove ST segment, a gradually descending segment, and T-wave inversion. That is a necessity. And then any of the following can be added to clinch the diagnosis. First, maybe you have documentation of an arrhythmia, an important arrhythmia such as ventricular fibrillation or tachycardia, or you can induce it with medications. Or you might have a family history, as in this patient, of sudden cardiac death and premature, will be labeled as less than 45 years of age, or maybe a presence of cove-like ECGs in your family members. And lastly, most of these patients will actually just fall flat on the ground, have syncope, or nocturnal agonal respiration. So remember the following key diagnostic features to raise your likelihood of diagnosing Brugada syndrome. Now, let me tell you a little bit about what's happening in the Philippines, and I'd like to recognize one of our preeminent cardiologists and electrophysiologists who has dedicated her life's work to Brugada syndrome. Dr. Giselle Hervasio has pioneered what we call the Brugada or Bangungot program. So in the Philippine vernacular, we call it Bangungot. And Bangungot, for the Filipinos out there listening, we sometimes call it a bad dream, someone who has died in his or her sleep. And back in the day, we thought it was due to pancreatitis or overeating. But thanks to the efforts of Dr. Giselle and other colleagues, they confirmed through autopsy studies that this is not due to pancreatitis, but really a genetic disorder with high arrhythmic potential. So much so now we are enjoying the fruits of the labor of this team. The Philippine Bangungot program or Philippine Brugada project aims to do two things, basically to look into the Philippine population and say, what are the specific genetic mutations or variants in this population that can be tied to Brugada, and can we confirm them? In a nutshell, this is the Philippine Brugada project, and I've gotten the permission of Dr. Hervasio to show this to our audience. The first phase is basically recruitment of patients. We see 19 to 60-year-old Filipinos with Brugada type ECG. And this is very crucial because if in this first step, we are not able to accurately pick up the type 1 ECG, that's going to be detrimental to the diagnosis. Next up would be, of course, getting pedigree data and clinical data, genetic analysis, functional studies, and of course, post-test evaluations. Now, that being said, let me now bridge you towards a talk about AI and electrocardiography heading towards Brugada. And we know for a fact that artificial intelligence is very useful for electrocardiography in the following respects: early screening, diagnosis, prognosis, and treatment selection. And you're going to see this in full display when the other speakers take their turns. So to my mind, it is very crucial, especially to the young trainees out there, to remember that AI is very vital for electrocardiography for three things: evaluation of rhythms, correlation of ECG findings with the clinical presentation, which is very important, and generation of conclusions regarding what's going to happen to the patient next. Now, moving forward, let's talk about ECG, AI, and Brugada. There are a variety of ways where we can use AI to diagnose certain conditions, and that is based on the electrocardiogram. Your ECG has signals, has images, printouts, text reports. And what we see here is current work is focused more on the first 3 rows. So what we need to do right now is to move towards multimodality evaluation and hybrid imaging so that we can address what we call the black box phenomenon or the issue of explainability. What are some of the current models for Brugada diagnosis? So I've pulled out 2 very significant work. First by Mello and colleagues who came up with a deep neural network, and they were able to accurately classify Brugada syndrome. The accuracy is 88% with an AUC score of 0.93. Liu and his colleagues came up with a bidirectional model and with fairly good sensitivity and specificity as well. What are the current hurdles? Why are we talking about AI work on Brugada? I'll tell you some of the more important things. First of all, Brugada possibly is quite rare or maybe underdiagnosed, and the existing training data sets are really skewed towards normal. It's going to be hard to really come up with good data on Brugada that is confirmed. That leads to what we call class imbalance. Then, of course, I mentioned most of the data and the work come from Asia for probably some good reason, and there's limited validation. Next, of course, is the ability to distinguish the patterns. Most of current work focuses on type 1, but I think it is worthy to look at the types 2 and 3 to probe for their clinical significance. Some of you might probably have encountered the transient Brugada pattern. Some ECG findings are very intermittent, fleeting, or dynamic, and you're going to miss that on your single ECG. And certain clinical conditions can actually mask or unmask them. Very importantly, as I will highlight in our local work, the black box problem. Most models will lack transparency, and sometimes even if it's accurate, it's hard to believe it if you cannot understand and explain it. There are validation limitations because of sample size, and of course, we know there are a lot of differentials for ST elevation and the ECG, which can mimic your Brugada pattern. So much so that 3 years ago, we already started some collaborative work in the Philippines, a cardio AI working group at the Philippine General Hospital. And we focus on 3 things: Brugada syndrome, cardiac telerehab, and clinical electrocardiography. So I focus on the AI Brugada project. So thankfully, with the help of a lot of experts outside their field, what I realized during my AI journey is to be humble enough to reach out to people who have more expertise and know-how. So part of the authorship here are experts in computer science, machine learning, and of course, AI. I'd like to highlight particularly Professor Pros Naval, who is a preeminent AI expert in the Philippines. So what we try to do is to propose something novel, an explainable detection system for Brugada on your standard surface ECG using existing large language models. So to simplify the discussion here, we get our raw ECGs, try to digitize them, extract certain ECG features that are indicative of Brugada, pump them into a large language model, and then augment this model with published literature, and finally come up with a heightened medical report. Here are some of the images that we've used. As you can see here, the digitized ECGs and how the model should be trained well to identify certain landmarks, because this is critical to the diagnosis of Brugada syndrome. What was the model performance? I'll just go straight to what we found for the diagnosis of type 1 Brugada. It had a predictive value of 100%, sensitivity of 66, and specificity of 100%. Of course, much more is in store in terms of improving and training the model. But what are the benefits of this particular novel approach? Well, first of all, there's an element of explainability and transparency, not to mention the fact that it is backed up by literature that are vetted by cardiology experts, and that will hopefully translate to clinical interpretability and applicability. Another interesting thing here is we know for a fact that when we conduct AI work, we need large data sets. But when we have this particular hybrid model, then there's lower data requirement because all you need is the large language model and a set of criteria. So I'd like actually to end my talk here. That is just barely scratching the surface on Brugada syndrome and the electrocardiogram by highlighting that Brugada syndrome or what we Filipinos call bangungot, is actually probably more prevalent than we think, and we need to diagnose it in an accurate and timely fashion. And one way to diagnose it is to make good use of the electrocardiogram. And we need to couple our human intelligence with artificial intelligence to really augment the way we pick up this particular condition. And that brings us, of course, to the element of humility, where we have to collaborate with our colleagues and even with AI to help us come up with the most viable solution to this particular dreaded disease. I'd like to end my brief presentation there. Thank you very much.
Thanks so much, Dr. George Donato Magno, about this AI-assisted detection of Brugada syndrome. So it's a great sharing. Also quite happy to see from the Philippines that the program. So you promote the AI with the ECG in terms of 12 ECG for this Brugada the detection.
Yes.
As I want to ask the panels, all our speakers and the co-chair, any the quick questions to Dr. Yos? Maybe let me start the quick question to for this sharing. So question one is regarding the the landscape for this Brugada in the Philippines. Do you happen to know the numbers or prevalence of a Brugada in Philippine population? That's the one.
Yes,
Second is that how likely they are able to do the early detection using the conventional, the 12-lead ECG, in for the community or to the cardiology hospital. So that's two quick questions.
All right, great question. So actually, I did mention earlier that the prevalence in the Philippines is 0.2%. That's roughly 1 out of 500 Filipinos. And that's actually massively higher than the worldwide prevalence, which is around 0.005. So I believe it is grossly underdiagnosed because we're now seeing a lot of people which seem to present with the Brugada syndrome but have not been confirmed, maybe genetically or electrocardiographically. So to answer your second question, by the way, I'd like to give a shout out to Dr. Giselle Hervasio, who is actually online here. And she's very instrumental in the Philippine Brugada project. So this particular dedicated project is one attempt to really consolidate efforts to become more effective in screening and catching these people early. And I'm glad that in the Philippines, even geneticists are coming forward to help us out in doing these projects. So, but much has still to be done. I think one great thing that's happening now for the APSC cloud form is really education and awareness, especially not just for the doctors, but for the lay.
Thank you so much. So due to time limits, we also see the Professor Lin Chinson online. And very good afternoon, good morning, actually good afternoon to Prof. Lin. Can you hear me? Okay, so are you okay to introduce a second speaker? Prof. Lin, are you okay to introduce Dr. Liu Wei Ting from Taiwan? Okay, maybe he cannot hear me, but everyone, can you hear me? I can introduce Dr. Wei Ting Liu. So the second speaker is Dr. Wei Ting Liu from Taiwan, and he is attending physician from a division of cardiology, Department of Internal Medicine, Service General Hospital. He will present a prediction of a sudden cardiac death by AI-enabled ECG in sinus rhythm, along or combining with the underlying cardiovascular health profile. How good, respectively? Yeah, Dr. Liu, your time, please.
And thank you, Professor, for your kind introduction. And I'm opening my slide. And can anyone see the slide?
Yes, it's great. Please, your time.
Okay. And I'm waiting here from Tri-Service General Hospital from Taiwan. And I would like to share how AI ECG right now could predict sudden cardiac death in both sinus rhythm alone or combined with underlying health profiles. And would like to share some relevant studies that have been published right now and some from our team. And my outline is to introduce the background of sudden cardiac death and how AI ECG to predict sudden cardiac death and also to identify the causes of sudden cardiac death. And finally, I would like to discuss about the management after AI prediction and current evidence gap. And the etiology for sudden cardiac death between regions differ. And most of the sudden cardiac deaths are caused by coronary heart disease. As you can see, in the Western country, there are 70% of them are caused by coronary artery disease. And this article takes Japan as the example. Like in Asia, about 25 to 50% of them of sudden cardiac deaths are caused by coronary heart disease, and followed by cardiomyopathies, inherited arrhythmia, or valvular heart disease. So if the AI ECG need to predict sudden cardiac death, they need to detect this kind of etiology. And the cause of sudden cardiac death also differ in different ages. In young ages, primary are electric disease like CPVT, long QT syndrome, or like Brugada syndrome, just I mentioned above. And coronary anomalies or cardiomyopathies and myocarditis also happen in a young age. But when the patient goes to their foster case or in older, most of the patients were caused by the coronary artery disease, especially acute coronary syndrome or other structural heart disease. And the risk factors associated with sudden cardiac death are mostly similar to those with coronary artery disease, like old age, male sex, and cardiometabolic syndrome, and obesity or low socioeconomic status. And we can see the incidence of sudden cardiac death also increase with age, and most of these patients are suffer from coronary syndrome. And how to train an AI ECG model to predict sudden cardiac death? I think there are two ways right now researchers are trying to do. First of all, they directly target the incident cardiac arrest event. They know the ECG and how long after the ECG the patient will suffer from the cardiac arrest event. Or they directly compare the ECG to screen for the etiology of a sudden cardiac death that I just mentioned above. And I would like to talk about the first one. And this study used an ECG model, used the pre-arrest ECG to predict the out-hospital cardiac arrest event. This is a study from the United States. They used the Oregon sudden cardiac death registry. There's about 1,700 cases of sudden cardiac death, and they are matched control about 1,000 patients. And as you can see that most of the patients with sudden cardiac death don't have a pre-sudden cardiac death to have ECG. So they exclude a amount of patients after their screening. So only 1,700 cases were included. And they also use an external cohort for validation. And if you compare the AI ECG model and conventional ECG risk score, like this conventional ECG risk score, like resting heart rate, LVH, QRS transition, QRS T angle, prolonged QTC, or T peak to T end interval, we can see that if you use the AI ECG model, they combine the whole, use the entire AIG signal, the AUC will achieve 0.88 in the internal cohort and 0.82 in the external cohort. It's better than the traditional ECG electric risk score because the AI use the entire ECG. They may use other features other than human selection. And if the AI ECG combined with clinical risk predictor like age, sex, heart failure, coronary artery disease, diabetes, COPD, or other cerebrovascular disease, we can see that using clinical variables alone, the AUC is 0.78 in internal cohort and 0.8 in external cohort. And the performance will improve greatly if the AI combined with clinical variable. The AUC could achieve about 0.9. So the clinical variable do improve the AI ECG model performance and is needed to combine with AI ECG model to achieve better performance. And the performance of AI ECG to predict sudden cardiac death also differ at different time points. This study used AI ECG to predict 1 year all-cause mortality, and the AUC is around 0.88. But in our own study, we found that the AI ECG is more capable of to predict short-term mortality. The AUC is 0.93 in the 90-day mortality prediction and 0.96 to 7-day mortality prediction. So the AI ECG could predict more near-term events than a long-term event. So this is another study published last year that used the ECG to predict a near-term sustained VT event. They used a 14-day ambulatory ECG recording from 240,000 patients, and they used the first 24 hours recording to predict the sustained VT in the following 13 days. And you can see the results show that the AURC of this AI model had a 0.5 both in internal and external validation. And although this model achieved a relative high accuracy, but because the incidence of sustained VT in this cohort is quite low, about 0.545%, so the positive predictive value is only 12%. And the AI ECG model also had a better performance when the prediction horizon is shortened, like in the future 1 hour, in the future 1 day or 2 days, is better than prediction 13 days event. And also the performance will drop significantly when use lower and smaller input, like the data within 1 hour or 6 hours. It will be better to use the 24-hour data to predict sustained VT. And this study also showed that how AI ECG predict this event. They show that the PVC burden is the one key predictor, and also they analyze the waveform, and they can see the onset of the QRS is very important. Maybe they will see delta wave or early depolarization pattern or abnormality along the ST segment is the key predictor by this AI. So the AI could predict accurately sudden cardiac death events, and the clinical factors could also improve the AI performance, especially for near-term prediction. However, we can just know that there's an event, the patient is high risk, but it is not directly to the management. We still don't know the etiology. So some research team try to use AI ECG to screen for the etiology of a sudden cardiac death. And of course, coronary heart disease is the predominant cause of sudden cardiac death, and half of the sudden cardiac death patient were not diagnosed with heart disease before. So the ESC guidelines suggest that the most effective approach to prevent sudden cardiac death is screening for CAD. So one article used the AI ECG to target the patient presenting to the emergency room, and they want to predict the patient will receive coronary revascularization with either PCI or CABG on the index admission. And they use the MIMIC-4 database, about 180,000 patients. They also compare the AI ECG with cardiac troponin and clinician ECG interpretation. And we can see that in predicting revascularization during index admission, the ECG model will achieve an AUC of 0.91, higher than cardiac troponin T or clinician AUC, clinician interpretation. And the odds ratio is highest in ECG high risk, followed by chest pain, for ECG intermediate risk and cardiac community. And if the AI ECG should predict type 1 MI, and the ECG also achieve quite good AUC, similar to high sensitivity troponin around 0.85. And although this AI ECG model could predict accurately, but another problem is also the positive predictive value is still low because the low incidence of these events. For intermediate risk, the positive predictive value is 3% to 2%. And even for high risk predicted by AI ECG, the positive predictive value only 14% to 17%. So this study is done by our team, and we want to expand the AI ECG in the general population, not just limited to the patient visiting emergency room. And we also exclude patients with acute coronary syndrome. We want to see all stages of coronary artery disease, maybe the AI could predict. And you can see that AI ECG model could predict new onset revascularization. The C index is 0.81. And in high risk group, the hazard ratio is 11-fold. And even the patient did not receive revascularization within 90 days after the ECG. This patient, high-risk patient, will also have a high risk in future acute coronary syndrome events. So these patients are not currently now have acute coronary syndrome, but they are at risk for future ACS events. And another etiology is the cardiomyopathies for sudden cardiac death, and there are several causes. And I will take hypertrophic cardiomyopathy as an example. This paper discuss they used AI ECG model with 3,000 patients with HCM and 63,000 patients H6 major control. And they show a quite good AUC, about 0.95 to 97 in predicting this HCM, including both obstructive or non-obstructive type. However, the positive predictive value shown by this paper is around 31%, but the prevalence in this match cohort is overestimated about 4%. And generally, we know that the hypertrophic cardiomyopathy is around 1 in 500. So the positive predictive value might be lower at the general population. And if we compare the traditional ECG criteria, LVH ECG criteria, we can see that the true positive and the false negative as the HCM cases, and only 49% or 10% of them meet the ECG LVH criteria. So if we only use the ECG LVH criteria alone, maybe half the patient will be missed. So it's the opportunity for AI ECG to further improve the HCM detection. And inherited arrhythmia, like a previous speaker just talked about the Brugada syndrome. I will take the QT syndrome as an example. And this team used AI ECG to identify long QT syndrome in patients with initial suspicions and transfer to a specific EP clinic. And there are 900 genotype confirmed long QT syndrome and 1,000 patients that consider normal after detailed examination. And the AI model could identify long QT syndrome with an AUC 0.9. And if you use QTC alone, the AUC is 0.82. I think it's quite comparable. Now, using QTC alone is quite okay, but this paper also compare if the patient came with initial concealed long QT syndrome, means their initial ECG QTC is less than 450, and the AI model still can correctly identify these patients with AUC 0.86. higher than using QTC alone because their QTC is not high enough. And if we compare this Schwartz score, which is the diagnostic score for long QT syndrome, they not only capture the QTC length, they also want to compare the T wave and the heart rate for age and other etiology. So maybe the AI could correctly identify other features other than QTC to identify long QT syndrome. So the AI seems to have a high AUC to identify the etiologies of sudden cardiac death, and we can manage this patient as the detected disease. However, these are mostly rare disease, so their positive predictive value will be low. So maybe a lot of high-risk patients will be false positive. And it turns it's another problem is how we manage these AI high-risk patients. If they say this patient had some kind of etiology like HCM or long QT, maybe we can perform examination for them. But if the patient predict high mortality risk, it's hard to know what to do for this patient to reduce their mortality risk. So in our team, led by Professor Lin, they done the randomized control trial. They use an AI ECG alert intervention. They will send a message if the patient had a high mortality risk predicted by the AI. And we randomized 16,000 patients to either intervention group or control group. And the intervention group will be alerted by the AI ECG if the patient had a high mortality risk. They will send alert message to their physician doctor, and their doctor will examine or check the patient status. And we can see our primary outcome is all-cause mortality in 90 days. And in high-risk group after AI ECG intervention, the mortality risk is reduced. The hazard ratio is 0.69 in high-risk group and no effect in the low-risk group. And overall effect, the AI ECG intervention will reduce the all-cause mortality by 17%. And the secondary outcome is the things that we want to know. What will the physician do to the high-risk patients? So we pre-specify some secondary outcome, and we also see that the ICU admission will be higher in this AI high-risk group, and amiodarone use will also increase, which may be caused by the doctor will perform more ECG monitor and find out more arrhythmia. And echocardiogram and proBNP or precursor exam also increase in the intervention group. So the doctor will perform more examination and maybe an intensive monitor. So the patient might reduce sudden cardiac death event. And this also supported by the cause of death. We can see after AI ECG intervention, the cause of sudden cardiac death is decreased by more than 90%. And they also have an effect to non-cardiac death. The hazard ratio is 0.76. So they also help the cardiac death and non-cardiac death. However, there are still some evidence gaps right now. Most of the study for predicting sudden cardiac death or their etiology are retrospective modeling, and prospective validation of this model still lacking. We still don't know the real-world performance when prospective validation, and the clinical action followed by the high-risk ECG finding remain poorly defined because if the patient are alarmed by the AI ECG, the following action will be crucial to determine the effect of the AI ECG will be useful or not useful. And low positive predictive value for the sudden cardiac death prediction because the lower disease prevalence may also lead to the alert fatigue and attenuate long-term clinical impact because physician will think the AI ECG is not accurate because many false alarm. And in conclusion, the AI ECG model has demonstrated good performance to predicting or detecting sudden cardiac deaths and their underlying causes. And using clinical profiles will further improve their prediction. And as a clinician, and understand the strengths and also the limitation of the AI ECG model will enable to their optimal use. And finally, the real-world impact of the AI ECG across diverse population or age groups or healthcare system still need to be established. And thank you for your attention. And I would like to take any question.
Thanks so much, Dr. Liu. It's a great sharing the how we can use the AI and the ECG to do the risk prediction, in particular for sudden cardiac death. Two quick questions. Question is related to the program or study at the Taiwan or Taipei. Do you happen to know you have any registry study looking at the clinical ECG and also with the outcome because of sudden cardiac death? That's the one. Could be the region, could be the national one. Second question is that in your hospital, because we understand you are tertiary hospital, what are the most challenge to adopt or to develop and adopt the ECG with the AI for the sudden cardiac death prediction? Is it due to limited number of case, or is it limited for some technology, or what other potential limitation there?
Thank you for the question. And the first one, I think our ECG developed in our hospital, and we've now promote it to other hospitals. There are about 13 outlying hospitals that are now using our AI ECG model. And we're trying to prospectively collect this data to know whether this is also useful in real-world application. But because the data we haven't collected them all, and we want to see a longer effect, so I don't have an answer right now. And I think no other research right now in Taiwan. Some of the hospital may have their own AI ECG model, but we haven't seen the data yet. And the second question is the most difficult things I think is to, I think the technology will not be the problem. The main problem is the case number, and especially for certain causes of sudden cardiac death. Like we've tried to develop our own model for hypertrophic cardiomyopathy, but in our hospital we only have like 100 cases. But this number is not enough for training a deep learning model. We may need more case number, like the paper done by the Mayo Clinic team. They have 3,000 cases, and this will lead to dramatically drop of the AI performance because they don't have enough cases for learning. So their performance will be not correct enough. So I think the most problem in most of the hospital or research team will be the number of the rare cases. Maybe we will need to collaborate many hospital or even international to make our own Asian Pacific model.
Yeah, thanks so much, Dr. Liu. I think that's a great comment. In particular, for second question regarding the sample size. Actually, in the Southeast Asia or Asia Pacific, that's an opportunity to can initiate some collaboration under the APSC, because all the hospitals are facing similar the questions that the limited samples, as you are mentioning the hypertrophic cardiomyopathy. I think also that's 100 or 200 cases. Maybe that will limit the power for the AI model. This is right for sure. So but at least is a good start. At least we can see the ECG from all the literature. We can see the AI with ECG have some good performance for some scenario, but for some specific, we can kind of call for action for potential collaboration in APSC. Thank you, Dr. Liu. Any comments or questions from our participants?
Yeah, I think could you hear me?
Yes.
Sorry, because my microphone has some problems. So yeah, I think the national collaboration is necessary. Now we did the AI ECG in our hospital and also our country. We do the multi-center validation first, and then if we get the permission from the TFDA, we can do the multi-center clinical trial. Because I think the cross device and the cross race has some accuracy dose. So the international collaboration is necessary to prove its real effect. And also not only for the rare disease, but I think the most application potential would be the in hospital and emergency patient, because usually we need to identify those look well but has subtle disease, and this population we need pay more attention for that. Thank you.
Yeah, very good comments. I think it's kind of good time. I think also this is a very good network for the APSC from different cardiac society from Taiwan and Singapore, Philippines, and also at least by today we have several representatives from different cardiac society. Thanks so much for Dr. Liu, and due to time limits, we are moving for next speaker. So let's welcome Dr. Rompichai Chokasuwa Watanasku from Thailand. He is a associate professor of medicine and also co-chair at the Center of Excellence in Arrhythmia at Southern Cardiac Death, and from the Chulalongkorn University, Bangkok, Thailand. He will present AI-powered ECG identification of STEMI in the facilitating emergency PCI real-world experience. Please.
Good morning, everybody. Thanks for the APSC to let me as a part of this meeting. And I'm pleased to be the representative from the Heart Association of Thailand. Today, I'm going to talk about the use of AI for the ECG identification of STEMI. Just want to try to get the audience know the similarity and the differences between the first two topics and my talks. So the first two topics focus on the disease that is rare, and it's hard to find an adequate sample size in our region unless we have a good collaboration internationally. But my talk will be focused on the common disease, which is the acute chest pain presented with the STEMI. But the things that we need to take for our own region clinical practice is how can we adopt the fancy AI models into our clinical context, which has a lot of variations. So I wouldn't deny that a lot of patients in our region experience the higher incidence of STEMI because we adopt more westernized culture, foods, and increase the body weight and incidence of the obesity. So just want to try to focus on using the AI to facilitate the care in the real world practice is going to be the issues of importance because our region has a pretty limited resources to take care of the patient across the regions. This is my disclosure. So I'm going to divide my talk into two main parts. The first one is how we develop the model. And the second part would be the clinical application in the real world clinical setting. So when we are looking into the AI models, they usually divided into many different categories. But the categories of the AI that is dealing with the images, including the ECG or the CAT scan or even the cardiac MRI, we call the CNN. So we need to be familiar with these terms of AI, that the CNN is convolutional neural network. It's kind of the process that it can learn from the image by dividing the image into a tons of grids. When I said a tons of grids, mean if you look at the bottom, you can see the pictures of the EKGs. If you look at the bottom, you see the pictures of the EKG. You can see that ECG itself can be divided into different portions. If you look at the EKG, you can train the AI model to see which part of importance that you want AI to focus on. We were talking about the sudden cardiac death. That way, or that patients, we particularly need to train the AI to look at the fragmented QRS complex, which put the patient at risk of arrhythmia leading to the sudden cardiac death. But as opposed to the sudden cardiac death, when we focus on the ST elevation MI, we need to train the ECG model or AI model to focus on the ST segment. And how can AI learn to appreciate the difference of the ST segment from the normal? We need to train them both normal ST segment and the abnormal ST segment could be STEMI or other non-ACS ST elevation. So after you have enough number of the patients with the ST elevation MI and the normal population, then you can tell the AI that, hey, this is the ST elevation MI, and that is not ST elevation MI. And that is the way that the AI can have the capabilities to tell the differences between the STEMI and the normal population, or even with the non-ST elevation MI. When we get a closer look to the EKGs, we can see that this is the example of the patient who presented with in the emergency department with an acute ST elevation MI. First, if we need to develop the model to let the AI to learn and differentiate between ST elevation and the normal ST segment, you need to give the correct input to the AI models. So when you give the correct input to the AI models, you need to tell the AI that and label the ST segment as the normal or as the abnormal. And then when you get the adequate numbers of the patients, you will learn automatically to improve its accuracy to identify the ST elevation MI. Getting even the closer look into the small red box, you can see that even with this small red box, we need to train the AI to know which part is QRS complex, which part is ST segment. What is the difference between the ST segment and the QRS complex? You need to get the AI knows the difference between each component of the EKG. And I think this is very important things that we need to talk about, because in the AI models, even with the EKG files, in our regions, a lot of regions, including Thailand, we still use the paperwork. When I said paperwork, mean that you have the different EKG formats. Different EKG formats mean some center might print it out as a physical paper. Some center might print it out and export as a PDF files. Some centers export the files into the MATLAB format. Even with this difference in the exported files could make a huge difference to develop the AI capabilities. This discordance or this inequity of the ECG machines across the regions make a lot of difference to develop the good models to train the AI to recognize the ST segment elevation. Here's the workflow to train the models. We need to, in the summary, I start with the sequence from the first one all the way down to the fourth one. So the first one is convolutional layers. It means that this is the kind of the AI that can look into the data as the images format. By looking into the image, you can see the different spot on the image as the grid. if you look in the grid, you need to train the model to recognize the different complexes in the EKGs. And with an adequate numbers of the patients and the information input to the AI, it will learn how to recognize the ST segment. And then putting all together, pulling the layers, you can simplify and train the AI to have the stepwise approach to identify the ST segment, followed by to tell the difference between the ST elevation and non-ST elevation segment. Eventually, it will be fully developed and will be readily used in the clinical context. With a lot of data prove the good diagnostic accuracy of the model, ranging anywhere between 0.8 to 0.99. There's still some limitation that I just want to point out to the audience, that in some particular area of the heart, let's say this is the study just want to providing the AI models to tell the regions of the culprit lesions from the ST segment elevation EKGs. In the left main disease, which we already know that there's going to be very subtle change in the ST segment compared to these three regions, which has particular more than 1 or 2 leads that display the ST segment. What does it mean from this table is, if you have very subtle change of the EKG with a less number of the leads that show abnormalities, then the AI developed to tell this area would become less efficient compared to other three regions that has so many leads to define the area of interest. Let's move on to the clinical applications. So in Thailand, we are still on the process of developing the AI, but we are not to the point that widely adopt the model cooperating into the clinical practice. But what I'm going to show you all is, I think the STEMI, it's a very important disease, as we are taking care of the patient and just compete with the time. So draw to balloon is the key or is the surrogate marker to prove its benefit of the AI into the clinical practice. I'm going to focus on the few next studies that published, mainly focus on the study that adopt AI into the routine clinical practice. I think a lot of people, including the faculty of medicine, faculty of engineer, we develop a fancy model in internal validations. But when it comes down to the external validation or the real world clinical evidence, we need to look in the clinical context that has the limited use. And the most important question that we always need to address the concern to our society is how much we can rely on the AI to make the final diagnosis and bring the patient to have the invasive procedures. What do I mean by that? Just try to imagine when we see the patients with chest pain, how certainty we are to bring the patient into the cath lab by making the diagnosis just from the AI. So I think AI, it's very smart assistance, but still it could not replace the human clinical decision making. The role that AIs will become to play in the near futures, it would be the doctor's office assistants and facilitate the emergency department for the risk stratification rather than being the number one of making the diagnosis. We still need the physical or physician to be the part of the final diagnosis. Why that? Other than from the legal issues, I think the humans can adapt the information getting from the patients into the clinical context, which is going to be very important and more efficient than just looking into the AI. Because a lot of variants of the ST elevation could not still be recognized by the AI. For instance, early lead polarizations, Brugada type 2, This ST segment elevation might be interpreted by AI to be the ST elevation MI from ACS. And we don't want to bring those patients to get unnecessary intervention like cardiac cath. So just keep in mind and looking at the caveats of using AI, be sure to do it or to use it as the physician assistance rather than to take it as the replacement of the doctors. So this is the thing that we need to talk about in the next few randomized studies. The first one is AI-assisted pre-hospital ST elevation detection. If you look at the studies, this is the studies that just want to prove that using the AI to assist the doctors in emergency department to make the diagnosis of the ST elevation compared to the intervention arm. Intervention arm is the AI assisted, and the control arm is the traditional way. When they pick up the patient out of the hospital, bring the patient on ambulance, get the EKGs, send the EKG file to the doctors at the emergency department. This is what we call the traditional arm, compared to those with AI guided approach. And with the AI interpretation of the EKG, it can stratify the risk of having the STEMI and alert the physician at the emergency department. If you see that, it's very makes sense to show that the response time should be very fast and even much faster in the AI because it doesn't need the human to or the lag time from the human because human is always busy on something else in the emergency department, but AI is always available for you to get the feedback to the EMT in the ambulance. So we did not surprise from the result in this study showing that with the response time in the AI group, it's much faster compared to the physician arm. And when it moved forward to the randomized studies, these studies just want to try to prove the concept of using the AI as the physician assistance to compare the door to balloon times between the arms that use the AI versus the arm that is the traditional approach. So the arm that use the AI, that just use the AI to stratify the patient at risk to have the STEMI with the high risk or high pretest probability of the STEMI, if you directly alert the EKG to cardiologists, not the general practitioner in the emergency department. And most of the highly alert EKG of the STEMI will go with the correct diagnosis and get the better door to balloon time. This is one of the very first studies to prove the clinical benefits by using the AI to assist in making the diagnosis. The benefits comes mainly from making the good stratifications and send those high-risk EKGs to the cardiologist and shorten the door to balloon time. And this is another study just want to prove to tell the physician that the AI model has equivalent capabilities with the high sensitive biomarker from the internal training model and translate into the external validation from the European countries. It proved that the AI model trained to diagnose the high-risk coronary artery disease need emergent coronary revascularizations. The capability of diagnostic accuracy is pretty close to the high-sense troponin I, right? They both are far better than clinicians' diagnostic capabilities for the patients who require emergency department. So here comes to my final slide that I think from my own personal thought that we need to address the concerns before going a step further to adopt the AI in our regions. So data standardized between hospital or among different hospitals, it's very important. I discussed about the different format confer the different capabilities of the trained AI models. So if we can use the models that developed from one regions, it may not be able to use that model from different regions if you get a different format files of the EKGs. And we had a problems with that one because our center, we are working on a lot of Brugada patients ablation. Our center published the BREF studies. We tried to use the EKGs in the paper format, and we had a hard time to train the model efficiently to recognize the type 1 Brugada pattern. So this is the thing that we need to make sure we have standardized our EKG recording in our regions. And we need to improve the medical personnel knowledge on AI to use it efficiently. More importantly, external validation is crucial to make the AI models to be more generalizable into the real world practice. And I think some barriers that we are still facing is the medical personnel knowledge on the AI. And I think the most issues that we might push forward is trying to incorporate AI models into our emergency department for the risk stratifications, because so many regions we do have inadequate numbers of the doctors. In some province, we might have 1 or 2 interventional cardiologists that cover 1 or 2 million people. So stratify the risk of the patients who need the most urgent care would be the most beneficial from the resource limited setting. And a variety of a control group needs to be enrolled in the randomized studies to prove its benefit on the use of an AI model assisted in the ST elevation in my diagnosis. Thank you very much.
Thank you, Professor Ropicha. I'm very impressed about your talk and also the challenging issues. I have 2 questions for you. And the first one is, now the AI model to detect acute coronary syndrome focus on the, we call it OMI, occlusive myocardial infarction. So have you tried the model here in your place? And then I think I totally agree with you that the multi-center external validation is very critical. So do you think that digital format will be beneficial for that? Because if we use paper, that is not convenient for each hospital. Thank you.
Yes, thank you very much, Professor Lin, about the questions. I think this is the key things that I think everybody wants to use the AI to facilitate the care in the remote area. But they are not aware of the disparities of the data acquisition, especially with the images like EKGs. And so many regions, let's say in our hospital, we have a very good digital format files, developing the models, have the internal validations. But the main limitations of our model is we could not get a good result from the external validations. It's just because a lot of remote area like this, the suburb areas, with the ambulance going to the scene, having the EKG done, I would say almost 99% of those ambulances are equipped with the physical paper EKG. And when you took the picture from the phone, send it back to the center, I think it's pretty impossible for the AI to recognize the lower than standard resolution image compared to those images that it was trained by the model. So this is the main limitation that we need to universally have the standard ECG acquisition in the same format. And that couldn't be done without the implementation from the top to the bottom. That is my thought.
Thank you. Thank you very much. Because of the time issue, I think Professor Liang will help us or I can introduce the Professor Dr. Si Hong Yang is assistant professor in Seoul National University Hospital, and his talk is AI-enabled quantitative coronary computer tomography in prediction of acute coronary syndrome, coronary plaque, flow dynamics, and more. Let's welcome Professor Yang. Professor Yang, please.
Yeah, thanks for a kind introduction, Professor Lin. So I'm Seokun Yang from Seoul National University Hospital, and it's my honor to be speaking at APSC Cloud webinar. So today, I'd like to talk about AI-enabled quantitative coronary plaque and hemodynamic analysis, namely ICFA, in HCS prediction. So most HCS events arise from clinically silent lesions, so that identifying high-risk coronary lesions before the event and modifying that risk remain the major clinical challenge. So our team aim to address the question on how to better predict HCS event before the event using CCTA and AI algorithms. So the current standard reporting system of CCTA is mainly based on the anatomical stenosis, but with advances in imaging analysis, we can obtain more comprehensive plaque and hemodynamic features using CCTA. So when we talk about the concept of plaque vulnerability, it generally refers to a certain plaque morphology, including lipid poor, large necrotic core, thin fibrous cap, or intraplaque hemorrhage, which have been shown to be a precursor of future rupture event. And previous studies have demonstrated that these morphological plaque characteristics can be quantified on CCTA. For example, fibrous fatty and necrotic core volume, or percent low attention plaque volume defined by low Hounsfield unit, were independent predictors for future HCS or MI event. And in addition to these morphological plaque characteristics, plaque quantity is also a critical component of MI development. Throughout the investigation of percent luminous stenosis, according to time to MI event, the rapid plaque progression has shown to be an essential step before MI. And in histopathology plaque feature analysis among sudden cardiac death patients, 70% of ruptured plaque was present in severe stenosis lesions. So when you look at the correlation between plaque quality and quantity, the clinical data have clearly demonstrated that the prevalence of vulnerable plaque, such as syncytial fibroatheroma, namely TIFA, or ruptured plaque, was significantly increased in relation to an increase in percent area stenosis. But despite this correlation between plaque quality and quantity, their prognostic impact was known to be synergistic. In the PROSPECT 2 study that traced outcomes of non-corporate lesions on an HCS patient, lesions were divided into 4 groups according to high plaque burden and high lipid-rich plaque, and only lesions with both high plaque and lipid-rich plaque showed a significant increase in major adverse cardiovascular event, while other 3 groups did not. And this finding was also consistent in our registry data analysis, so that when we find plaque vulnerability, plaque quantity, as well as morphological plaque characteristics should be considered. And beyond these plaque characteristics, the local hemodynamics surrounding the plaque also plays a central role in pathogenesis of acute coronary syndrome. For example, high Weisser test or high pressure gradient acting on the plaque can act as a biological stimuli for plaque progression, transformation of vulnerable plaque, or even plaque rupture event. And the clinical data also show that the lesions with high visual stress is associated with the higher risk of future MI event than those with low visual stress. And as of now, these local hemodynamic parameters also can be obtained on CCTA by using imaging-based physiology known as FFRCT technology. It employs computational fluid dynamic analysis, and it provides local hemodynamic parameters non-invasively using CCTA. So our previous study has shown that the CCTA-derived visual stress, axial plaque stress, or delta FFRCT, which is a differences in FFRCT across the region, or pressure gradient, were all correlated with each other and provided prognostic values for future ACS prediction in addition to low FFR and high-risk plaque. So likewise, CCTA now provides comprehensive lumen, plaque, and hemodynamic assessment. So we aim to explore the additive impact of this comprehensive assessment over standard CT interpretation criteria. That's why we performed MLR2 study, which was an international multicenter study, then enrolled from 32 centers of 9 countries, and designed as an internal case control study. Patients undergoing CCTA and subsequently experienced ACS 1 month to 3 years later after medical follow-up were included. And according to the pre-specified lesion definition criteria, a total of 2,451 lesions were identified on CCTA, and standard CT analysis were performed by 2 independent radiologists at UBC. And IFA was independently performed by half flow, and then culprit lesions were defined on invasive coronary angiography at the time of ACS. And then by matching with CTA images and invasive coronary angiography images, all CT lesions were labeled as either culprit or non-culprit lesions, and their lesion characteristics on CCTA were compared. So standard CT analysis included the CAT-REG scoring system based on the degree of stenosis, and also it includes the conventional definition of high-risk plaque defined by the presence of 2 or more adverse plaque characteristics, including low attenuation plaque, spotty calcification, positive remodeling, and neck-filling sign. And IFA, provided by HeartFlow, provided the plaque volumetric parameters such as total, non-calcified, low attenuation plaque, and their relative plaque volume, as well as hemodynamic parameters such as visual stress, axial plaque stress, delta FFRCT, and total myocardial blood flow parameters. And the primary hypothesis of this study was that the addition of IFA features into the standard CT interpretation criteria will enhance the predictability for ACS culprit lesions. So here are the baseline characteristics. The mean age was about 66 years old, and 2/3 patients presented with MI at the time of ACS event. And the median time to event from CT to ACS event was about 1 year. And as compared with non-culprit lesions, culprit lesions had a higher degree of stenosis, higher number of APC, higher plaque burden, and higher delta FFRCT. So let me briefly show the main result of the MLR2 study. The relative importance of IFA features was compared using information gain criteria, and 17 IFA features were grouped into 5 clusters using hierarchical clustering, and then we defined the 5 best IFA features having the highest information gain from each cluster, which were delta FFRCT, plaque burden, total plaque volume, low attenuation plaque volume, and averaged % total myocardial blood flow. And then we found that the indiscrimination of ACS culprit lesions versus non-culprit lesions, the addition of these 5 best IFA features significantly increase the predictability of the reference model with the standard CT interpretation criteria. And moreover, this finding was also consistent in the independent validation cohort, so that we concluded that the primary hypothesis was met. And when you look at the AUC changes according to time from CCTA to ACS event, although the AUCs of the both models tended to decrease over time, but the additive value of alpha features remained consistent regardless of time from CCTA. And the application of Shapley analysis showed that the potential for the discrimination of ACS culprit lesions by using these alpha features into the standard CTA area for individual cases. So the main conclusion of the MLR2 study was that the alpha features provided the additive predictive values for ACS culprit lesions over the standard CT interpretation criteria. And then in a subsequent post-hoc analysis, we would like to explore the similarities and differences of these four domains, namely luminal narrowing, plaque quality, plaque quantity, and local hemodynamics with ACS culprit risk, to better understand how they may relate to ACS risk and also how they may be integrated because they are closely correlated with each other. And as you can see, the increases in degree of stenosis, the number of APC, plaque burden, and delta FFR CT were all associated with the higher risk of ACS culprit risk even after adjustment for each other. And in the mediation analysis, these four domains show the significant both direct and indirect impact on ACS culprit risk, indicating their independent contributions to ACS culprit risk despite their intercorrelation. And then we directly compare the diagnostic performance of these four domains, and high plaque burden show the highest sensitivity and negative predictive values for ACS culprit lesions, while high delta FFR CT show the highest specificity and highest passive predictive value for discriminating ACS culprit lesions. And this trend of sensitive nature of plaque burden and specific nature of delta FFR CT showed a consistent trend across the different cutoff values. And based on this result, when you plotted the overall ACS risk by anatomy versus delta FFR CT, and you can see that there was about 18% of these column cases. However, the lesions with both high-risk anatomy and high-risk physiology portended the highest ACS culprit lesion risk, followed by discordant cases and concordant low-risk cases, indicating the potential synergistic impact between anatomy and physiological characteristics. So, luminal narrowing, plaque quality and quantity, and local hemodynamics were all independent predictors of future ACS event, offering specificity in physiology and sensitivity in anatomy, allowing them to provide complementary and synergistic prognostic value. And then we extended our focus from the ACS occurrence itself to the time to ACS event. We hypothesized that the different coronary lesion characteristics can indicate the varying ACS risk and time to ACS event, as shown in these two different high-risk plaque presenting with different time to ACS event. This concept is clinically important in determining the optimal treatment strategy for both patient and physicians. To do that, we divided the MLR2 study population into three groups according to different test to event time within 1 year and 1 to 2 years and beyond 2 years. The overall patient characteristics were not significantly different across the three groups. However, when you look at the association of ACS culprit characteristics with test to event time, an increase in luminal narrowing and local hemodynamics and relative atherosclerotic burden were all associated with the shorter test to event time. And this relationship resulted in temporal changes in relative importance of lesion characteristics. In prediction of short-term HS event within 1 year, delta FFRCT, plaque burden, degree of stenosis, and the number of APC were the best feature representing local hemodynamics, plaque quantity, lumen, and plaque quality, but their relative importance changed and decreased over time, in particular beyond 2 years. And this trend was also consistent in predictability for HS corporeal lesions with combined model with all these 4 characteristics. The predictability tended to decrease over time with a significant reduction beyond 2 years, and this result indicates the optimal prognostic time frame with these lumen, plaque, and hemodynamic characteristics was within 2 years. Based on this result, we focused on the prediction of the HS event within 2 years, and we found that these 4 binary features were independent predictors for HS within 2 years. And based on the result, we divided all lesions into 16 lesion subsets based on the combination of these 4 lesion characteristics. Among them, 6 lesion subsets showed a rare prevalence, which was clinically insignificant. And among the remaining 10 lesion subsets, only 4 lesion subsets showed a greater HS risk than the average proportion, which were 4 positive, 3 positive, with obstructive lesions and high plaque burden, and either high APC or high delta FFRCT, and 2 positive with high plaque burden and high delta FFRCT. And the explainable machine learning algorithms show that the delta FFRCT was a main driver of an increase in HS risk within 2 years among the majority of the high-risk lesion subset. And based on this result, we proposed the hypothetical algorithms for primary prevention of HCS using IFA. So by application of IFA features into CCTA, we can obtain lumen, plaque quantity, and quality hemodynamic features with the optimal time prognostic time frame within 2 years. And within this time frame, high-risk lesion subset can be defined with the combination of these 4 features, and this lesion subset may benefit from early revascularization because the time window for risk reduction only with medical treatment may be limited. In contrast, as for non-high-risk lesion subset, they may be suitable for meticulous medical treatment, and follow-up CCTA beyond 2 years can be recommended. So my final conclusion of the talk would be the prognostic significance of lumen, plaque, and hemodynamic characteristics was most relevant to HS risk within a certain period, which was 2 years in our study. And the integration of IFA features with the machine learning-based risk modeling for time-dependent HS risk allows for the personalized risk assessment and treatment. Thanks for your attention.
Thank you very much for Professor Yang, very interesting talk. I have one question for you. Regarding for the CCTA machine AI training, usually the image format is very important because we know the image protocol are usually different from hospital to hospital. So I just wonder what's your policy to have the uniform image format? Because if we don't use the uniform format, it will be difficult to extend to other hospital. Thank you.
Yeah, thanks for the important comment, the professor. So I totally agree with that point. So for the standardization of CCTA protocol across the centers and nations are important to better apply our knowledge into the CCTA so that we generally perform the CT protocol with the strict control of heart rate and the recommended use of nitroglycerin before CTA. And also in our MLR2 study, the CTA should be greater than 64 detector. And also we believe that the penetration of recently introduced photon counting detector CT can enhance our plaque and hemodynamic and lumen analysis in the future, I think. Yeah, thank you for your comment.
Thank you very much. So I don't know if any comment from the audience.
Thank you, Dr. Yang. I'm waiting you from Taiwan. I have a question. If the CCTA found that the CT-FFR is lower, is needed to be intervention, but when you do the coronary angiograph and found that the angiography sees this FFR is within normal range, will you still do the intervention or you will defer the lesion?
Oh yeah, so thanks for the comment. So you mean the discordance of FFR values between CT versus invasive metrics, right?
Yeah, that's right.
Yeah. So for those cases, actually, in my humble opinion, I just believe invasive metrics because invasive metrics of FFR represent both epicardial and microvascular circumstance, but only CT image based FFR was derived from the stimulation of by with the hypothesis of several assumptions like correlation with of blood flow with myocardial mass or hyperemic response of microvasculature that was they were obtained by hypothesis. So that generally I believe invasive metrics first and CTFFR I used as a just a gatekeeper. Yeah, thank you.
Thank you.
Thank you.
I have a quick comment.
yeah,
Thanks
Professor
so much,
Liang.
Dr.
Yeah.
Yang. It's a great job. I love this hemodynamics, in the coronary because coronary physiology play a very important role for academic research, but also potential clinical practice. And if you're able to incorporate this hemodynamic, delta FFR or CTFFR into the coronary disease, that's tremendous value. But also we can ask in the young, there are any thoughts that, can involving all these APSC society to do the Asians, collaboration. Of course, Singapore happy to join the support, and maybe Taiwan, Philippines also quite happy to, to join to make a bigger the cohort of on behalf of Asia. Do you have any thought and any idea to share?
Yeah, thanks very much for your nice suggestion, and I would be love to join the collaboration with APSC. So the main challenge would be the data collection across the nations, but I believe we can do that because the number of CTA scans across the nations will be dramatically increasing. So thanks for your nice suggestion. Yeah.
Okay, thanks so much. I may contact you for potential or possible, sharing or collaboration.
Okay, thank you.
Thank you. Maybe we move to the next speaker. Yeah. So next speaker will be Zhong Liang from Singapore. Professor Zhong Liang is from the National University of Singapore. Today, his talk is AI-based assessment of prediction of procedural risk and the long-term outcome in aortic and mitral valve interventions, multiple image modality needed or not. Let's welcome Professor Zhong Liang.
Okay, thanks so much, Prof. Lin, for the kind introduction. So everyone, can you see my share screen here?
No. Yes.
Okay, thanks so much. Yeah, so very good afternoon to Prof. Lin and all the speakers. It's great and an honor to hear, and very great to hear the first 4 speakers talk about the AI, ECG, AI, and the CT for different scenarios. So today I'm happy to share some, understanding for AI-based assessment and the prediction of the prostate risk and long-term outcome in the aortic and mitral valve intervention and the multiple imaging modality needed or not. Yes. So this one is that we are talking about the AI, but actually beyond the sudden cardiac death, beyond the coronary disease, the valvular disease also quite big issue is growing the global problem. With the aging population, we are seeing very steady increase in the prevalence and the corresponding rise in the clinical burden. So at the same time, there has been a major shift towards the transcatheter therapies. So they are less invasive, but they're also more complex in terms of planning and decision making. So let's looking at the transcatheter therapies. Today, we commonly perform TAVI for aortic stenosis, TER for the mitral regurgitation, TMVR or TTVR for the more complex disease. These therapies have revolutionized care, but they're also highly patient-specific, and the outcome can vary significantly from one patient to another. So why risk prediction matter? Because it's being as a key issue, even with the very advanced therapies, but we still see posterior complications and the variable long-term outcome. So the question becomes, can we better predict who will benefit from intervention and who may not? So let's looking at the traditional, because if you can do that, we can improve patient selection, optimize the treatment strategy, but also automate improve outcome. Look at all the traditional risk marker, quite busy slides here, but we can see that the tools that the STS score, Euroscore 2, all are quite well established and the clinical also useful, but they are limited. They are largely based on the clinical variables. They do not fully capture the anatomical complexity and also imaging information. So this one, the Euroscore calculator. So now is that how we able to bring the AI in, because as a result, this prediction, the performance is how moderate to fair. So you can see all these AUCs, the Euroscore 0.61, 0.60, and the long logistic Euroscore 0.56. So we consider this performance is only moderate. They meet the key elements that the patient-specific anatomy, device tissue interaction, the posterior complexity. These lead to a shift towards an AI power approach. So let's look at the multimodality imaging. In the modern valve intervention, we rely on multiple imaging modalities. For example, CT is for anatomy and the caution. Echo is for the hemodynamics. CMI is for function and the tissue characterization. Each provide different piece of information. So the challenge is how to bring them together. So AI in valvular heart disease, AI can support across the entire care pathway before the procedure for the planning and risk assessment, or during the procedure for the guidance and the positioning, and after the procedure for the prediction outcome. So now we are moving towards an end-to-end decision supporting system. AI workflow. The workflow quite straightforward in concept. We start from the multimodal data, they apply the AI for image processing and the segmentation. We extract the features, build a model, and generate predictions. The key step here is the integration of the data. So now let's looking at the why multimodal data fusion is matter. Because no single modality tells the full story. As I mentioned earlier, CT is for the anatomy, echo giving function. CMR give tissue information. So when combined, we get a more complete picture. This allows more accurate patient-specific prediction. So you can see all these together, they're able to do better. Let's looking at the one example for the AI for the aortic root. Yeah, this is a very good example because traditionally, TAVI planning require manual analysis. You need to measure the dimension. You need to do segmentation for the valve structures. So all these quite time consuming. Roughly take 20 minutes per case. So with the AI, this can be done automatically or semi-automatically with a higher accuracy. So around 10 times faster. This enables a scalable and a reproducible workflow. So now let's looking at the measurement. So if you're looking at the AI, after you do the measurements, also we are able to do the AI and the 3D modeling. We can simulate the posture and we can predict the complications like the paravalvular leak because of leakage, leaflet thrombosis, and even for the aortic rupture. So this moves us towards the virtual posture planning. And the accuracy, you can see that high accurate versus expert observer up to 0.98, but faster. This enables rapid, reproducible TAVI planning. And this one for the model development. Machine learning models that this one, the models able to capture complex and non-linear relationship, and they outperform traditional risk model. So they can support both the treatment decision and the posterior management. So you are able to see from the right-hand side all these paravalvular leakage simulation, but also we are able to do the aortic root rupture simulation. This is somehow is beyond the traditional parameters or traditional risk model. So this one given some ideas how this simulation with the AI or machine learning can do better than the traditional parameters or traditional model. Risk model. We need the TAVI risk model because the score. So we need very special model to predict the posterior risk. And this one at the moment is quite largely lacking. Yeah. So reasons mentioned by the other speakers, lacking of data, lacking of long-term outcome. So the machine learning based risk score can capture this very complex the information or relationship between the multiple variables, and also we are able to do the pre and the post TAVI risk. So outcomes are able to predict 30 days mortality. These are for the early discharge decision. So this is a paper in the European Heart Journal 2023. For these models, we can see that the accuracy from internal validation, external validation, and roughly we can see that the score, the C index around 0.79, 0.75. It's not perfect, but compared to the traditional risk model I mentioned earlier, around 0.6, so that can see the improvement. So this can show the potential to support both the treatment selection, but also the posterior management. So this is top predictor features. So intervention duration and the serum creatine, patient's characteristics, age, race, gender, and echocardiography. This is very important for the TAVI because the peak AV gradients, mean AV gradients, heart function, and PAP, but also including the TAVI anatomy, like the annulus diameter, and also coronary head. So what we can see the right-hand side is all the variables importance with this trim, the post. So after TAVI also important because this is a machine learning for pacemaker implantation prediction after TAVI using the multimodal imaging data. And this is in the data from 2024. And we can see actually quite complex that involving 67 the variables from the 420 patients. And this is also quite complex, the framework. But when you pay attention to the accuracy, look at AUC, it's up to 90% accuracy. So again, this shows academic performance, but also we can see the potential value of these models. Now let's looking at the technical failure. This is very important in the TAVI surgery because the technical failure can occur around 10% of a TAVI due to cardiac or vascular. So the prediction is challenged due to the complex multifactorial interactions. So data-driven machine learning model using the multimodal data can improve the prediction of posterior failure. So this is quite sizable of patients with up to around 3,000 patients and involving the 184 multimodal variable clinical imaging postures and also looking at the outcome defined by the VARC technical failure. So this is how the model was developed. Data set splits 70% for training, 30% for the validation. So this is very common for AI. Feature selections and followed by the classifier. So they are developed 6 different classifier: random forest, lasso model, logistic regression, linear. So I think all of you have some experience for different classifier development and with the 24 unit models. So from here, what we can see the failure rate. So around cardiac 2.4, vascular 7. So altogether around 10%. Accuracy 0.77. Vascular similar 0.78. So very good. We can see actually a high negative predictive value up to 0.995. So here are the key predictors for the failure: atherosclerotic comorbidities, CT-based aortic roots, and anti-thrombotic management, also posterior features. So this one, for CMR, because we are looking at a CT, of course, it carries a radiation, but still able to provide the information. How about other imaging modality? I just mentioned we have several. So CMR is considered alternative because it's important clinical consideration that the patient cannot tolerate the contrast due to the kidney disease. So in these patients, the CMR provide the alternative. The study shows that the CMR guided planning is not inferior to the CT. So this is one study. We can see 380 patients with severe symptomatic aortic stenosis. They randomized 1-to-1. So you can see that the CMR guided versus the CT guided. This is a paper in Circulation 2023. So what we can see during the follow-up with the 180 days follow-up, so there's no significant difference between the CMR guided planning versus a CT guided planning. So this one is very promising to show that another imaging modality can help this TAVI surgery. And now we're looking at the mitral annular segmentation. This for the TTER tier, because patient selection is more critical. At the moment, relies heavily on the expert interpretation, but AI can automate this process with the performance comparable to the expert and also faster. So this enables a more consistent decision making and also across center. So let's looking at this one also can move into the tricuspid annulus and also looking at the deliver angle and device positioning. So this is a very valuable for another one, TTVR. So the echo. So echo fluoroscopy fusion for the structural intervention become a more and more clinical relevant, provide the real-time guidance for the transeptal puncture, for the chamber overlay for TMVR or TEER. Also, we are able to do the red heart guidance for the TTVR posture. So we do this echo fluoroscopy before, during, and after. AI for the TTER, TEER, the stability assessment. And the current suitability assessment rely on the expert echocardiographers, a bit time consuming, subjective, and also have high inter-observer variability. And the conventional scores limited integration of the multimodal imaging, also not optimized for the modern tiered workflow. So this is a paper in JAHA, and to show this deep learning and for the automated pre-operative suitability assessment using the multi-view multimodal echocardiography. Now let's looking at this tier pre-framework, and this is good data sets with the 633 patients and the 150 patients for the external validation. So this is a framework, and you can see the input in this red square, and also the model architecture, and output is a classification into unsuitable or challenging or ideal. So that tree the classifier. And we can see that the internal, external, the accuracy is also reasonable with the 75-73%. Compared to the clinicians, somehow is better. Yeah, it's outperforming junior and intermediate, and comparable with senior expert, but it's faster. So this giving us some ideas. This one able to support our junior, intermediate, the experts. AI phenotyping for the function metric regurgitation. This is another scenario for the tier. So the current challenge again, that's patient selection, and also that limited ability to capture the complex patients, heterogeneity, and inconsistent prediction outcome. So this paper in the European Heart Journal in 2025 to show the machine learning phenotyping is help that this transcatheter edge-to-edge repair from the mitral AS study. So this study design, and we can see that including the unsupervised learning and the inputs beyond the clinical variables, but including very good echocardiography parameters. The output is identification for different phenotype, different phenogroups, and we can see the outcome also that looking at the composite of cardiovascular death or heart failure hospitalization at the 1 year. So here is the high risk and the low risk. So we can identify the tier, the non-responders, and also the risk stratification. So let's looking at the performance. The performance is everyone, if you're looking at the 1 year mortality and versus the high risk versus the low risk. So that's significant. The 1 year, the CV deaths compared to low risk. So this one to show us that the classifiers is somehow is good to classify the patient into the low and the high risk. Now let's looking at the bridging to practice. We talk about this different transcatheter intervention for the valvular heart disease, include TAVI, TMVR, TIER. So AI models show the promising, the risk prediction. AI also demonstrates accuracy with the multimodal imaging and the clinical data. So the next step is to understand the limitation, also unmet the challenge before the clinical adoptions. And this one is very important for the next, we call the research, also clinical trial. Let's looking at the challenges. There's several key barriers. The data, heterogeneity, and second is the multimodal, the fusion complexity. The third is limited outcome data, and then in particular lacking of long-term outcome data. And you can see for all the studies are looking at the 180 days or 1 month of outcome, and important lacking of interpretability, and the clinician need to trust this model. And the last one is for the model integration. So this one also another big challenge, and a lot of hospitals at the moment cannot incorporate this the AI model into the real-time the procedural planning. So what's the future? The future directions, if looking forward, we are moving towards a large standardized data set. Second, more advanced AI model, but importantly, we can consider the digital twin. This able to do the patient-specific virtual model, can integrate the imaging, able to do the simulation with tissue device interactions, And if a 4D flow available, can consider is a pre-surgical planning. In particular, have a multiple jet of leakage. And the clinical translation, this one is a matter with the policy change, but also the capacity to interpret the results from the AI. Last slides for the home message. Variable heart disease is increasing globally. Transcatheter therapies are becoming the standard. Traditional risk score are not longer sufficient. AI and the multimodal imaging enable automated assessment, personalized prediction, improve the outcome. But of course, we understand challenges I mentioned just now, but the future lies in the fully integrated patient-specific decision system. So ultimately, the future not just predicting the risk, is about the simulation and the optimization, the best treatment for each individual patient. So we hope in ASPC, we are able to do, because I understand a registry in Southeast Asia, in particular for the metro clip. But for the TAVI, TIR, TMVR, with the AI, also we can consider potential collaboration. Thank you for your attention. Yeah.
Thank you, Professor Liang. Very amazing, wonderful talk. I just had two questions. I know the outcome of structural intervention may be operator dependent. So do you include the operator factor to the AI? And this is the first one. And the second one, I see the data from your AI training is mostly for the structural data, like as you mentioned, the variable of echo, CMR or CT. Do you try to use the lung structure such as the image for the AI training for prediction? Thank you.
Thanks so much, Prof. Lee, and this is a very good question. And the first question regarding the operator factor, for sure, this is, that's one study show that if you compare to the senior expert, the junior or intermediate, so we call the failure case is higher. So this one is very important, in particular for this transcatheter intervention for variable heart disease. You need very rigorous training. So short answer, I think this is a very good idea to incorporate whether you are junior or senior. So that's one can able to improve the performance of our AI model. So beyond the imaging, beyond the clinical data, and that's the one that I do believe that's one of the key the factor. Second one is kind of a echo CMR CT. Probably can you repeat the question again? You talk about these three imaging modalities.
Yeah, I know that you have all multiple image modality, but you includes the structured data or the unstructured image information. I mean, structured data like the ejection fraction or LV, or you use the image to show the ejection fraction. Yeah.
I see. So now actually all the models most likely is using that we call the ejection fraction. So based on the measurement, and of course for different, for example, TAVI, you are able to do some measurements, annulus dimension, and the ventricular dimension. That's why it's based on we call the output from the imaging analysis. So as I mentioned, in the future, I can see there's a few potential technical advancements in the digital twin. So it means I got the imaging only, the input is imaging. We don't do any the measurement. Yeah, that's the future because I can put everything in. I do the acquisition for echo. I just throw in. So that's a one paper in Nature from a Stanford University School of Medicine just 2 years ago. They have a AI, so they are able to do the just purely echo images, no any the landmark, there's no any the annotation. So they are able to automate the recognition, the image, feature extraction from the image, measurement from the image, or without the measurement or image. So that's a kind of breakthrough. So that's the first paper in the Nature. And then after in the JACC, also published, for this AI for the echo, beautiful imaging for the model development. So this is a very good question, also a timely question. I think short answer is that at the future, just using the imaging, so clinicians don't spend time do the annotations and giving very clear the standardized data format, do the measurement, extract the variables to do this a very conventional, we call the forest model, whatever logical model. Actually, they're based on the variables. So this is a very, very good question. Imaging. That's it.
Thank you. Any other question from the audience?
Hello, Professor Liang. I'm waiting you. I just curious if there's any possibility that we can use the real-time angiography during the procedure to guide the guide the surgeon, because when every time we try to intervene or try to put the valve in the correct position, although we all have a lot of plan, but everything changed during the procedure. Do you think that the real-time AI will be possible during the procedure? Thank you.
So this is a very good question, a challenge question. Short answer, at the moment, no. So it means that no one doing in a clinical practice. Reason is that, again, how the AI, the model robustness, able to guide in the real time for the procedure. That's a one. So that's a risk. So now is that even for senior, because senior consultants, they don't want to take much risk using the AI model for angiography to guide in the deployment real time. Second one is also the power for the AI, because you need to consider all the information to give in the with real time feedback, whether you are able to see from this views, are able to give in the information. So from my understanding, this one also that one that's a 3 hospital that are doing the AI for the angiography, but still at the early stage. They do from the US, one collaborator from Canada, Toronto. So I read in a paper, the NJP Digital Medicine, and they consider this possible, but at the moment it's not clinical. So, but this is, I think, in for the physician doing the surgery, I think it's quite important. But now is that how you're able to get the data standardized at the posture, able to get this database with a good quality. That's a one question. So without the good quality of data, not able to train an AI model. Yeah, others is before surgery called planning. So yeah, a lot of time to fine tuning, standardize the sequence and acquire different images. And based on the model to the prediction also can, because you got the outcome. So most challenges are during the surgery. So this one, I think you're giving very sharp, but also critical question. I think about in Asia, we can try see whether we can do that.
Thank you so much.
Thank you, Professor Liang. Because of the time issue, maybe I just have one short comment. Maybe in the future we can integrate the foundation model or integrate the Gen AI to integrate it all the EHR, EMR. Maybe it could also have the predict better patient outcome. So because of time issue, now we invite the Professor Liang to give the final closing. Thank you, Professor Liang.
Thanks so much, Prof. Lin. And again, it's so happy and so great to see so many excellent speakers from Philippines. I hope that we can give applause to all speakers, Dr. Yos from the Philippines and Dr. Wei-Tin Liu from Taiwan and Dr. Ropin Chia from Thailand, Dr. Yang from the Korean, also my co-chair Prof. Lin and the program director, Professor Junlin Lee from the National Taiwan University Hospital. Thanks so much, APSC, for support this forum. So we hope in Asia, in particular for all the Asia countries, we are able to continue to develop AI for this cardiovascular disease, including the prevention, but also for the prediction. Thanks so much again to everyone and have a good day.
Bye-bye.
Thank you very much.
Bye-bye.
Thank you.
So 1 second. All the speaker, do you mind to open your camera, take a good photo so we can share the photos to everyone? I think that's that's one more? Doctor from Thailand. Okay, we will take one. Everyone look at camera. 1, 2, 3.
Yes, got a snapshot.
Okay. So thanks so much. I can put in the snapshot also in over the WeChat. We can see quite nice Pauline's face there. Oh, okay. So one more time. Dr. Ropicha coming. I hope you don't mind. We can take one more time. Everyone
Okay, one
here.
more. Thank you.
One more. Okay.
Thank you.
Thank you